Thanks for joining us for another IEA Reporter interview. I'm Dave Harbison, Communications Director of the IEA. We're now just a few short weeks away from a possible reopening of school buildings in Idaho. But in many areas of the state, the COVID-19 pandemic has not abated, and there's some difficult decisions to be made at the state and particularly at the local district level as to how to weigh the risks and rewards of reopening buildings. In order to separate fact from fiction and to get the medical and scientific perspective on this issue, we're speaking today with Dr. Kenny Bramwell. Dr. Bramwell is the System Director for St. Luke's Children's Hospital, previously served also as the Medical Director for Regents Blue Shield. Doctor, from a public health perspective, where do we stand now related to COVID-19 cases versus how things looked when the soft closure was announced back in the spring? Do we have more knowledge about spread, symptoms, treatment of the virus? How do things look different now than it did back in March?
Sure. Thanks, Dave. Those are some really good questions. The first question about how do we look now in comparison to how we looked in the spring, we actually are not in a great place right now. The number of cases that we're having on a daily basis are higher now than they were in the spring. That's certainly one component of how we're evaluating this from the perspective of the hospital and the system here. The other way that we look at it quite commonly, the first few things I do each day is I check how many cases we had yesterday and how many patients we have inside the hospital. We refer to them as inpatients. So I check those two data points each day, how many statewide cases and how many inpatients we have. So if you look at those numbers, or if you look at graphs of those numbers over time, you'll see that the number of cases we have now as a state is quite a bit higher than it was in the early spring. And that's certainly concerning. The other number, mentioned the number of inpatients, that's probably double now what it was in the spring. And that's a pretty strict number that we watch, like I said, really closely. The other things that you asked about, what do we know about symptoms? The symptoms that we know currently are largely the same as what we thought in the spring: fever, cough, shortness of breath. We've added a few subtle changes. For example, if a patient suddenly has a difficulty tasting or smelling that they hadn't had previously. In our Wood River Hospital, we found a lot of patients, elderly patients particularly, were having GI symptoms or nausea, vomiting, and diarrhea. More recently, the CDC has expanded their symptom list to include even vaguer things that overlap more with other illnesses like runny nose and a sore throat. So as we've added symptoms, I think it's gotten harder to tell the difference sometimes of this is COVID and this is another virus.
I'm glad you brought up the CDC. I wanted to ask you about their most recent guidance, and they issue these guidelines periodically. The most recent ones, they talk about a 5% or less positivity rate as being kind of the ideal, or what they would like to see for going back to in-person instruction in the schools. What was your reaction when you saw that recently?
Yeah, you're exactly right, Dave. That's the number that they used to say, hey, if you're below 5%, that would be the best time to open schools broadly. The challenge with the CDC recommendations as I see them, by and large, I'm very supportive of what the CDC is doing, and we pivot very commonly in response to their recommendations. But the idea that we should respond or we should wait until we get to 5% probably would prolong opening of schools for some time. The other sort of challenge we have from a public health viewpoint is that while we know the number of patients who are testing positive at any particular clinic or through any particular lab, what we don't know is what the positivity rate is across the state or even across a county. Because by and large, the people who are getting tested are not asymptomatic people, but people who are curious or worried that they have the illness. So while some of our clinics are seeing rates in the 10 to 15% positive range, we don't know what that means with the population as a whole. So we just have to take that number with a grain of salt, because we're not certain how accurate it is. In fact, we think the number of positive patients is probably a bit lower, but we don't have firm data.
The American Academy of Pediatrics released a statement a while back, I'm going to say 4 to 6 weeks ago, that sort of was the linchpin for this push to reopen schools. Then they came back and clarified that a little bit and said something along the lines of, yes, in an ideal world, an ideal situation, the in-person school is much preferable. I think that's largely most educators, most students, most parents would be in agreement with that. But so we know that there are definitely advantages to being in a school building for students, and that's face-to-face interaction with the teacher, the structure, and the socialization aspect of it as well. How do we in a very large collective group, but in particular those that are making decisions about whether or not to reopen school buildings, how should they be weighing the benefits of the in-person, and there are many, with the risks and the safety piece of this?
Yeah, those are great questions, Dave. I'll share with you the AAP, which is the American Academy of Pediatrics, tends to look at things from the perspective of the whole child or all of society, not just a strictly medical perspective. They raise a number of points. If you read their position statement, they talk about the social benefits of school, which I think you mentioned. We have data to suggest that between 40 and 50% of kids who attend school get some sort of assistance to eat their breakfast and or their lunch. There are a lot of resources, speech therapy, occupational therapy, school nurses, which are available at school. So there's a lot of other things there are many other things that go into the decision and sort of the support milieu for the students. So the AAP came out pretty firmly. I think if you look at it from the perspective of they're trying to promote school in person as best they can, I think their recommendations are pretty solid, but they have some mitigating suggestions as well. I don't think they came down so strongly, though some people may have perceived it like this, where they said you just have to open schools. But they did say the default should be, we're going to open schools in some fashion. And here are some suggestions. Here are 10 things you can do to mitigate the risks to the students and to the teachers to make it as safe as possible. So they were trying to change the discussion from, man, I don't think we can open schools safely, to
right.
Let's start with the idea that we're going to open, and let's figure out how that could work.
So to take that a step further, what's your reaction to the state of Idaho's guidelines, non-binding and certainly not mandatory, but kind of a red, yellow, green, three-tiered approach based on the spread of the virus?
Yeah, I think those guidelines are quite solid. They are, the hardest thing for all of us is the idea that we know exactly what's coming, or that we have done this before, are both flawed. I think everyone's doing the best they can with the data that they have at the time, and these are really, really hard discussions. I'm supportive in general of what Idaho as a state has outlined with the red, yellow, green that you mentioned. I think it's a little surprising to me from the perspective of public health and a hospital system that some of this has become as politicized as it has, rather than just, hey, let's talk about what we know and let's talk about making this safe for ourselves and our children. It seems to have degenerated from there in some circles.
All right, well, let's talk about what we know, or at least what you know as the expert in this. What is the latest scientific guidance then on large gatherings? We saw that reopening bars led to a lot of problems and growth in cases. And some communities, they've been shut down again. Concert venues, movie theaters, churches, all of those have been closed. Should school buildings be viewed differently for some reason, or if we're in any way as we talk about limiting large gatherings?
Well, hopefully no one's getting intoxicated at the school. Let's just start with that. But I think, I don't know that the school buildings are any different inherently, and I think the risk of gathering in large groups is similar in many settings. The challenge I think that we saw with bars is that people are drinking, people are getting louder, people are getting closer and closer together over the course of the evening. And I don't think it's surprising at all that those were sort of really, really effective places for people to share disease. I think the way that the school can be different, much like I feel like a work location can be different, is that with the various guidelines that we've talked about, washing your hands, keeping your distance, and wearing a mask, I think that you can mitigate a lot of the risks.
But is it reasonable to expect in a school building, especially when you talk about younger students, younger kids, that you can do the physical distancing that you're talking about?
Well, the physical distancing, I think in many scenarios is the ideal, of 3 to 6 feet, 6 feet being the best option, or 2 meters. I think the farther you're able to maintain or the better you're able to maintain your bubble, the better you're able to stave off disease. You know, it's one of the more interesting things for me in the last few months has been, and I can't remember the location. I want to say it was Kentucky. I could be wrong, but there were 2 hairdressers who had COVID and kept cutting people's hair with masks on, and their customers all had masks on. And there were a few hundred customers that they had, and they're up close and personal with these people for 15 to 20 minutes cutting their hair. And both of the hairdressers had COVID and nobody got sick. So what I take away from that is just the effectiveness of masks. If both people are wearing them, that they're really quite effective. Back to your initial question, though, you know, is it reasonable to expect that kids will stay 6 feet apart? I think that's challenging. Realistically, I think that's hard to expect, or that's a really high bar for many kids, because like the rest of us, they're pretty social, and they may violate other people's bubbles pretty regularly. But that's where I think having the masks on mitigates that risk. It doesn't eliminate it, but I think it takes it down to a very manageably low level.
Doctor, there doesn't really seem to be consensus about how at risk children are for contracting COVID-19, or how severe their symptoms might be. And now there's even new research indicating that they might have long-term effects, even if they don't have symptoms or effects immediately, but that they could have, that it could later in life, that it could sort of boomerang on them with very severe symptoms. What are you hearing about that, or what can you tell us?
Yeah, the jury is still out, I think, for long-term effects. We are 6 months into this pandemic, and I think the maximum we have is 3 to 6 months of follow-up on some patients who have had this illness. So I don't think we really know. Certainly, there are other viruses that have long-term problems. Chickenpox comes to mind, or the varicella zoster virus comes to mind. But I think we just don't know the long-term effects of the virus yet. To your other questions, kids seem to be unbelievably resilient to this disease. They get it quite commonly. They don't, perhaps below the age of 10, seem to be quite as effective at transmitting it as, say, the 11 to 18-year-olds or the 20-year-old groups. But though they get it very commonly, they seem to, by and large, be asymptomatic from it. And they also seem to represent very few of the deaths and the hospitalizations. I want to say the deaths so far in the below 10 age group are less than 0.1%. And the 11 to 18 year olds are slightly higher than that, but not by much. So it seems that children are, for the most part, getting off scot-free from this illness, where they only occasionally need to be hospitalized. They very rarely have a fatality, not zero, but very close. One of the strange things is there's a syndrome that's had a couple of different names over the last few months, where one child in a very, one child in a million, maybe one child in 100,000 who get this illness, ends up with a very complicated course and ends up in the intensive care unit, and has multi-organ systems that are affected and inflamed, and they need very advanced therapy. We have not had that in Idaho yet. I expect that we will. I believe at last count, there was one case in Utah, one case in Oregon, and one case in Washington State. But I don't believe we've had one here in Idaho yet. I suspect it'll happen as more and more kids get it.
So in the short term, then the kids are not terribly much at risk for maybe less likely to contract it, maybe less likely to have symptoms currently, but we don't know what they might be like 10, 20 years from now. And we also maybe don't know quite how much they're able to transmit it. If they take it home, do their family members who are in compromised situations get it? Or might they pass it on to a teacher, many of whom are in those at-risk categories, either from age or from pre-existing conditions? How do we approach that piece of it? Okay, the kids, we don't know for sure, but it seems less likely that they are going to be a problem. But are they carriers, and are they likely to infect others, educators, professional educators, or their family members?
Yeah, that's a great set of questions again, Dave. I do think that everyone's at risk from catching this disease from one another. Like you mentioned, the youngest children seem to be really effective carriers, but not necessarily getting particularly sick themselves. As far as the risks to teachers or to society at large, I think the best thing that we can do is engage all the other suggestions that we've really given to ourselves of washing our hands a number of times each day, and anytime you get exposed to the outside world, separating ourselves as best we can, 6 feet from each other, and wearing a mask when you're not able to separate reliably. I happen to think that those are really effective tools that we can all use, regardless of our health circumstances, to just try and prevent this from spreading from big kid to adult, or adult to other adult.
I mean, we're all hoping that we can limit the spread and flatten the curve, as the terminology has come to be over the past few months. But it seems inevitable, if we reopen schools and school buildings, that at some point a student and or an educator are going to contract COVID-19. What could or should the strategies be then when that happens?
So that's a really good question. I think what we need to do is reinforce the idea that we need to take exceptionally good care of ourselves when we're sick. And I don't think we're very good at that. I get the sense that many of us, I will include myself, many of us think, oh, I'm not that ill. I just have a fever and I'm a little tired. I think I can go to work and do my usual thing. And unfortunately, then I spread whatever illness I have to other people. I think one of the really important things we need to reinforce with each other, whether we're adults or children, is if you're sick, stay home. And we may need to adjust some of our work policies or school absence policies to give people the flexibility to just have a few days where they're at home.
Yeah, but we've seen restaurants, for instance, close down when a staff member tests positive for COVID-19. What's the recommendation if a staff member, if an educator, or if a student does test positive? Do they quarantine themselves and everybody they've been in contact with? Do they close down the school temporarily? What is the recommendation once we have a positive test?
Yeah, I think you'll see a number of different recommendations. Probably the most extreme is, hey, if somebody pops positive, that's just the slang that I'll use. If somebody pops positive on one of these tests, what are we to do? I think at a minimum, that person goes home and stays home for the next 10 days and waits until their symptoms abate before they come back to school or work. At a maximum, probably on the other extreme, you have really great public health engagement and the staff available to do what's called contact tracing, where they can say, I'll use me, Kenny got this virus, he went home. What are the places that Kenny has been in the last 6 to 8 days where he could have contracted this? And let's try and figure out how this happened, and contact the other people who were involved and say, hey, Kenny came down with this illness. We think you should know. and how are you feeling, and maybe you should get tested. That is the ideal, the ability to do that detective work or contact tracing and try and figure out what else needs to be done. So far, we haven't really had the manpower, woman power to do that sort of investigation in most circumstances. Sometimes we can do that, but for the most part, right now, the number of cases is high enough that we just can't keep up. So back to the question of what to do, I think that is really a great question, and I think that's what we need to try and figure out in conjunction. So each school district, and maybe even the state, frankly, should figure out, hey, here is our plan for what we do when somebody pops positive. If this is a teacher, if this is a student, here's what we're going to do. We are going to quarantine that person. We're going to have them stay home. We're going to work with them to get their educational needs met for the time being, if assuming that they were an in-person student for now. And let's figure out what else we need to do and who else may have been exposed. Probably the larger questions are, was there a breakdown? Because so far, there always seems to be a breakdown. Somebody didn't wear their mask for an hour. Somebody, frankly, it seems that most of the breakdowns don't happen at work or in school. Most of the breakdowns happen in gatherings. You talked about bars, or the large gatherings of people without masking and distancing come to mind. And unfortunately, those are really effective ways to spread disease, but they also are part of our normal life. And not everybody's comfortable giving that part up.
Right. And you mentioned staffing and the fact that we, quite frankly, don't have the staffing or the personnel to be able to do the contact tracing effectively. What about medical staff in school buildings? What kind of role could nurses or other medical professionals play in trying to mitigate the spread of COVID-19? And do we have enough of them, much like the contact tracing situation, do we have enough of them to make it effective?
I think the school nurses are a phenomenal resource. I think they're probably overtaxed currently. My understanding is we throughout the state typically have one nurse for 3 campuses on average. There are locations where that nurse would be responsible, say, for an elementary, a junior high, and a high school, maybe in more of the rural settings, but in some of our urban settings, it's 3 elementary schools or 2 junior highs.
Yep.
or what have you.
That's correct. Yep.
So I think they can be fabulous resources for helping people to understand the sort of importance of these various things that we've talked about modeling, in essence, social distancing, mask wearing, and washing of hands. It sounds a little crazy, but most people don't wash their hands very well. They don't do it long enough. They don't get all the surfaces of their hands very clean. That's something that I think a nurse could be really helpful to teach. I also think that the nurses on site could help with some of the kids who may not have the ability to go to see a doctor, or may need to have some screening questions about whatever illness they may have that day, where they can be checked. Admittedly, that could be an awful lot of people, but I do think that the nurses are a really valuable resource, particularly with this illness.
That whatever illness they might have today or on a particular day is an interesting sidebar here, because colds and allergies and the flu all have symptoms in many cases that are very similar to COVID-19, and those are obviously very common in school buildings. Will we be able to differentiate between them?
That is a really good question, and my answer is I don't think so. So the symptoms, let's say you have allergies, you're going to have a runny nose, you may have a cough or a scratchy throat in the morning, you may have red eyes. You can certainly have many of those symptoms from COVID. Typically they tend to progress, but early on, it's really hard to tell things apart. I'm not convinced that you can tell what is COVID and what is an allergy, or what is a common cold early on in the illness. And that's a problem, because the symptoms overlap so much that our tendency is to rely on testing, which is a bit of another problem that we haven't touched on yet, but that's another bugaboo.
Yeah, that was going to be the follow-up, because you're right, the symptoms are similar, so the only way in many cases you can really distinguish is through the testing. Do we have enough testing? Do we have enough testing that we can get results back quickly enough to be able to make that pivot and to quarantine those people, those students or those educators who have tested positive?
So early on, say 4 months ago, we did not have the ability to do the tests that we wanted very quickly. Fortunately, over time, that has gotten better, and we are getting more and more capable as far as the number of tests that we can run in any given week, so that, say, a month ago, we were in a pretty good spot. The challenge is that the number of people who need tests keeps going up.
Mm-hmm.
So if we were only testing people who were profoundly ill and needed to be admitted to the hospital, and we wanted to test that group to figure out maybe where to put them or what level of PPE was necessary to take care of them, that's one tier of patients. We're fine there. You get into the next tier, we've divided these up into 7 tiers. The next tier are people who are not severely sick, but have complex medical problems, and now they need surgery. Not appendicitis that they need in the next 2 hours, but they need their right hip replaced. And so before you have that invasive of a surgery, you want to make sure that they don't have COVID. So we test those people. As you go down these different groups of people, we get less and less able to take on the additional hundreds or sometimes thousands of patients per month. So the challenge went, as you get farther down this list of patients, when you get to patients who have mild symptoms or no symptoms at all, but were exposed to somebody, or alternatively, someone like my nephew who wants to go to Alaska to go fishing. Right now, we don't have the ability to do tests on all those people. And when we can do them, and the turnaround for those tests, which used to be good, has gotten bad again. So now it's in the 5 to 8 day range. So by the time you get your test back, let's say you have symptoms today, it's Monday, you call your doctor, they're going to see you tomorrow, they're going to test you, they're going to send it out. 5 to 7 days go by, and those are usually work days, not just all days. Now we're in the middle of next week, and you're 10 days into your symptoms, and you get your result back. Well, that's not really timely. That's not really helpful.
Yeah, it's not.
Because you should have been quarantining as a precaution during that time. And usually, if you're positive or negative, you can come back at that point and continue to practice the safeguards. But the test didn't help us in that scenario. And that's a real problem, is we have, we want people to have a test so they can come back to work or come back to school. And the amount of time it's going to start taking for these tests to come back, you say, well, I don't know if this test really helps us here. Other than knowing how prevalent the disease is, it doesn't help us about that one patient.
So just a couple more questions. The first one will put you back in your wheelhouse. From a St. Luke's perspective, or a hospital administrator's perspective, how concerned are you about the capacity of hospitals and the healthcare systems around Idaho if we're not able to slow the spread of COVID here over the next weeks and months before we head back into potentially sending students and educators back into school buildings?
A few months ago, Dave, my main concern was, oh my gosh, we don't have enough PPE for everybody. This is really scary, because we will go through all of our PPE in the next week or two, and that's going to be a problem for the next wave. I think we're through that phase. I'm no longer worried about PPE as the primary concern. What I'm worried about now is the hospital able to accept all the patients who are going to need to be hospitalized based on local prevalence and frankly, local practices of disease prevention. That's what has concerned me lately, and maybe more every few weeks, where I say, we're not trending well. The number of new cases that we have and the number of people who frankly, I think the more worrisome statistic is the second one, is the number of people who have needed to be admitted in our region continues to climb. We are currently still able to manage and take care of all those patients. One of the challenges is people with COVID come into the hospital and stay for prolonged numbers of days. People think, oh, you got plenty of beds. Well, our average length of stay for most patients is between 3 and 3.5 days. That's including the people who only stay overnight and including the people who stay for 14 days. But patients with COVID frequently stay for weeks. You read about people who have 100-day hospitalizations or 120 days. I mean, that's the real concern. Not so much that we cannot treat these people, as much as we are getting to a point where the number of beds that we have and the number of beds that are needed by our local population who gets and stays really sick, there's an imbalance there that's worrisome. It's not yet frightening, but it's worrisome.
Let's get back to the public school system to kind of close our discussion. How tough a spot do you think these, because it's been, the decision making has been passed down to local school districts. How tough a spot are they in, knowing that many of them are different for a variety of reasons, and who should they be listening to or getting input from as they make those decisions on, do we reopen schools? Do we close them down? Are we red, yellow, green? How should that process work?
You know, ideally, I'd like to see a consensus or a consortium of folks get together and try and help the individual school districts with perhaps a statewide approach. If that's not feasible in the short term, the best thing I think that the various boards can do is rely on one another. They probably have local medical and public health experts in their communities that they can lean on. They probably also have people who are used to managing large groups of issues as they come up in public health, the central district health, and those other government teams come to mind as well. I would try and rely as best as we all can on reliable, objective sources of information. The CDC website is fabulous. There are other reputable sites that I think are also really solid, but we take quite a number of our cues. I will share with you from the CDC website. I've mentioned the AAP as well. I think that's really insightful as far as thinking of kids as a whole person and as a family and as a society.
These have been and continue to be unprecedented times and a great deal of uncertainty going forward. So everyone is trying to make the best decisions they can, in many cases on the fly, and not having all the information they ideally would like. But thank you very much for spending some time with us and sharing your professional expertise. It's much appreciated.
Thank you, Dave. Have a nice day.